So I'm delighted to say that the landscape for treatment of patients with non-small cell lung cancer has changed enormously, particularly in the last 5 to 10 years. And I guess what's challenging doing an update on lung cancer at the moment is every single time you go to a conference, I sit there at the beginning of the conference thinking to myself, okay, what's going to have to change in the clinic next week when I get back home? So I guess there's an awful lot changing in lung cancer. And so one of the challenges today has been to hone that down into the things that have really been relevant to changes in clinical practice, everyday clinical practice over the past 12 to 18 months or so. So the focus of my talk this afternoon is going to be around immunotherapy, how immunotherapy has now been established in the treatment of non-small cell lung cancer. We've had at least three pivotal studies in the post-platinum treatment for non-small cell lung cancer of 3 different immunotherapy drugs. Each of those have demonstrated benefits in overall survival and progression-free survival, and somewhat tantalisingly given us an indication that we might have quite a prolonged improvement in overall survival with immunotherapy treatments for a small number of patients. So we saw some data at ESMO a couple of weeks ago suggesting that with immunotherapy we may be having 5-year survival for our patients with advanced disease of about 16%, which doesn't sound like much, but in the setting of stage 4 non-small cell lung cancer, actually we're used to numbers of being less than 5% for 5-year survival. So actually it's potentially a really big difference for our patients. So the changes in clinical practice have really been around second and third line treatment, post-platinum treatment, and we now have the options of using 2 PD-1 drugs, nivolumab and Pembrolizumab in that space. There's also data on atezolizumab, and that's going through approval processes at the moment. The other big change with immunotherapy, and the thing that's really going to change a lot in terms of patient pathway, is that Pembrolizumab has been approved for the first-line treatment of patients with non-small cell lung cancer if their cancer expresses high levels of PD-L1. So that's PD-L1 expression of 50% or more. And the key study, the KEYNOTE-24 study, demonstrated significant improvements in progression-free survival, improved response rates, improved quality of life for patients receiving immunotherapy compared to chemotherapy. And as a consequence of that, Pembrolizumab therapy for patients that have high levels of PD-L1 expression is now the treatment of choice. The impact that that has on our clinical practice is that previously, when we were needing to assess PD-L1 therapy, it was for patients that had already received first-line therapy, so there was no great rush for us to know what the PD-L1 expression was at the time of diagnosis. But now that we have a first-line treatment that is dependent on the PD-L1 expression, actually we need to know what that PD-L1 result is before we start treatment. So it has changed a biomarker assessment. So now it's not just that we need to know what the histological type is, we need to know what the EGFR and the ALK status is, potentially the ROS1 status, but we now also need to know for clinical practice, routine clinical practice, what the PD-L1 expression is before we start first-line therapy.